happy to be here today. Thank you also to Irish Cancer Society and the European Cancer League for the invite to talk on obesity, physical activity and cancer and the implications for policy. So I'll say a little bit about the World Cancer Research Fund, because I'm not sure how familiar you are with us as an organisation. A bit about the scale of the challenge that we face with obesity, physical activity. What the science tells us about the links between obesity, physical activity and cancer, and in the light of that, what kind of policy approach do we need? A bit about the evidence to support that, and then wrap up with a few summary points. So WCRF, the World Cancer Research Fund, we're not a single organisation. Sorry, the floor keeps creaking. We're not a single organisation, we're a network of charities. In the US, we're called the American Institute for Cancer Research, and elsewhere in the world, we're called the World Cancer Research Fund. So we have offices in the UK, in the Netherlands, and in Hong Kong. And WCRF International, which is the organisation that I work for, provides the overall strategic direction and operational support for the national charities. And we also carry out the main scientific and policy work of the organisation. And that scientific work, the messaging from that, underpins the health information, the communications, and the fundraising activities of the nationals. And you've got on your chairs a handout that says a little bit about our scientific work. So what do we do? Well, we fund research into the links between nutrition, physical activity, weight management and cancer risk. And we do that mainly through two grant programs. So we have one run out of our London office, the WCRF International Grant Program. And then we have one in DC, which is at the AICR grant program. And between them, they cover the whole world. So anyone in the world can apply to us for funding. And then we also look at the links between diet and cancer. And we use the evidence for that to derive recommendations for cancer prevention. We do that mainly through the development of scientific reports. Then we tell people about what we do. We educate them with our health information programs. And there's some information out in the foyer somewhere with some materials for you to peruse at your leisure. We have a number of audiences ranging from children's programs through to GPs, scientists, and a big health professional program as well. And then more recently, we've got involved in policy work, dipping our toes in the policy world to advocate for wider implementation of policies. And the reason we do all of these things is that we want to help people and populations to follow our recommendations for cancer prevention and reduce their cancer risk. So a bit about the scale of the challenge, and I won't be saying anything I think that you probably don't already know. So this graph is showing the incidence of new and predicted cases of cancer projected through to around 2030. And you can see that now around 2013, there are around 14 million new cases of cancer per year, and that's projected to rise to about 21, 22 million by the year 2030. What's interesting about this chart is the pink diamond that you can see on there, because that was the earlier version of this graph. So that was using data from Globocan from 2002, and in 2002, the projection was that in 2030, there'd be about 16 million new cases of cancer per year. And then updating this chart using the more recent evidence from 2008, the prediction has gone up to around 22 million cases of cancer. And I think that increase just underlines the scale of the cancer epidemic. There are some things that we can do, of course, to change this pattern, and there are some things that we can't. So cancer is mainly a disease of older age, and populations generally are getting older. There are also more of us around, populations are getting larger, and if you've got more people around, then more people will get cancer. But of course, there are some things that we can do, and they're the lifestyle factors, and we've heard about those already. So as well as getting older, we're also getting fatter as populations, and we're getting less active. And overweight, obesity, physical inactivity are very closely linked to cancer risk, as we'll see shortly. So those are the things that we can change to ensure that this prediction is not set in stone. So on obesity, there are now over 1 billion overweight and obese adults on the planet, which is more than the population of China, and works out at around 1 in 4 adults, which is pretty staggering. There are also over 40 million children under the age of 5 who are overweight in 2011. And as you know, children who are overweight are much more likely to become overweight adults and have a sort of lifelong struggle with weight. The picture isn't much better for physical inactivity. So a low level of physical activity is associated, is one of the top 10 causes of death globally, and that's because of the association between physical inactivity and the chronic diseases like heart disease, diabetes and cancer. And around 2/3 of Europeans are not meeting the minimum recommended level of physical activity. So with that background then, what does the science tell us about the links between obesity, physical activity and cancer? And I'm going to be talking mainly about this report, WCRF report. I might call it the green report, the second expert report, the diet and cancer report, but it's all the same thing. Feed, nutrition, physical activity and the prevention of cancer, a global perspective. So the report came out in 2007. The aim of it was to look at all the evidence that had come out until that point on the links between diet and cancer. A new methodology had to be developed to systematically review the literature, and around, or over 250 scientists worldwide were involved in putting the project together. And it took about 6 years in total. So there were 9 systematic literature review teams around the world, and those teams between them took on over 15 different cancer sites. And in their initial trawl of the literature, they identified about 500,000 potentially relevant studies. And then through a very, very rigorous selection criteria, that was boiled down to around 7,000, or over 7,000 of the most rigorous, the most robust, the most authoritative, the most credible studies. So those studies form the substrate for this report. So the approach took a so-called portfolio approach, so it looked at all the different kinds of evidence. So that was randomized controlled trials, epidemiology, and also mechanistic data, for example, cell lines and animal studies. Very importantly, the review of the evidence done by those SLR teams was kept separate from the interpretation and discussion of it. So the interpretation of the evidence was done by a leading panel of experts. There were 21 of them, and the panel was chaired by Sir Michael Marmot. So to help them with their deliberations to decide whether any particular factor was, say, probably or convincingly linked with cancer, wasn't linked, or there just wasn't enough evidence to say. To help them decide that, they had some criteria for the judgments. So I mentioned that this report came out in 2007, and we keep the evidence up to date using our continuous update project. So the continuous update project took all of those databases that underpinned the second expert report and has combined them into a huge kind of mega database which is housed at Imperial College London. And there's also an SLR team at Imperial that's entering all the relevant data since 2007. So this chart is showing the number of articles from a particular kind of study for the cancers that you can see listed there down the left-hand side. Now the green bars on the chart represent studies that went into the databases for the green second expert report. And the cut-off point for data entry for that report was 2006. And the earliest studies that went into the databases were from around the 1960s. So the green bars effectively cover, if you like, a period of time, of research time of about 50 years. The start date for entry for the Continuous Update project was 2007. And the cut-off point for this particular chart was 2012. So you can see that for a lot of these cancers, as much evidence, as much data has come out in the last 5 years as in the previous 50. So there's a huge amount of evidence of research that's coming out, and the Continuous Update project is a tool, a mechanism that enables us to keep track of that, to keep on top of it, to be able to interrogate the evidence at any point in time and see what it tells us about the links between food, nutrition, physical activity and cancer. And the reason that we're doing it, of course, is that we want to be able to keep those recommendations for cancer prevention current, so that they're always underpinned by the most up-to-date evidence. So what then does that evidence tell us, that weight of evidence about these links? So in a nutshell, the evidence shows that there's a strong link between physical activity and a decreased risk of postmenopausal breast cancer, endometrial cancer, and colorectal cancer. And the evidence also shows that there's a strong link between body fatness and an increased risk of esophageal, postmenopausal breast, pancreatic, endometrial, colorectal, kidney, and gallbladder cancers. So these links are what is seen in the epidemiology of the studies. So what's underpinning that? What are underpinning these patterns that we see at the cellular level? There's a fair amount known about the mechanisms that underpin what is then manifested in the epidemiology with obesity and cancer risk. There are general and specific mechanisms, and the general mechanisms apply to all 7 of the obesity-related cancers. So people who are overweight and obese tend to have an increased inflammatory state in their cells. And what that does is drive cell proliferation. It inhibits apoptosis, which is the method by which cells, if they're damaged, will kill themselves. And it also promotes the development of new blood vessels, which potentially could feed the development of a tumour. And that increased cell proliferation is such that it just overwhelms the cell's normal repair mechanisms. So it makes it more likely that errors will creep in, that mistakes will happen, and that they could lead then to the development of cancer. Then people who are overweight and obese also tend to have insulin resistance. And in order to compensate for that, to keep glucose homeostasis constant, the body increases the amount of growth factors around, particularly insulin growth factor. And what that does is it takes care of the glucose levels, albeit at a bit higher level than someone who's not overweight. But it also leaves these circulating growth factors floating around, which again will drive cell proliferation and could hasten the transformation of potentially malignant cells. So then there are also site-specific mechanisms that are linked to specific cancers. So breast and endometrial cancer, these are the hormone-driven cancers. And they're driven by estrogen production from body fat. So body fat isn't just a sort of inert tissue that's sitting there not doing very much. It's physiologically very active tissue. It releases hormones and it acts as a kind of hormone pump. That then causes, again, cell proliferation, which potentially can lead to the development of these cancers. And then there are some very sort of localized specific reasons. So gallbladder cancer, for example, you get an increased chronic inflammation in the biliary tract, purely through gallstone formation. And in esophageal cancer, gastric acid reflux can cause inflammation in the esophagus. Both of those things, again, set up chronic inflammation, which can lead to cell proliferation and hence more likelihood of cells becoming malignant. There's not anywhere near as much known about what underpins the protective link between physical activity and a decreased cancer risk. But it's thought that the same general pathways are involved, but just in the opposite direction. So physical activity is protective because it reduces cell inflammation, it reduces growth factors, it reduces hormone levels, and collectively that has a protective effect. So these are the top line recommendations from that Green report. And you can see that the top 3 of them are directly obesity and physical activity related. And that's because of these very strong links between them and cancer risk. And you can see that the very top one, body fatness, be as lean as possible within the normal range of body weight. And notice that it says body fatness. And that's because there's a graduation in risk even across the normal range. So of course it's fantastic to be anywhere within the normal range. But if you can possibly achieve it, it's better to be in the middle of the normal range than at the top. It's better to be at the lower end of the normal range than in the middle, because the evidence very clearly shows that there's a gradation, as I mentioned, across the normal range. So the idea is that following these recommendations provides a kind of blueprint for cancer prevention. And more recently, a couple of studies have come out just this year that show that following the recommendations also reduces the risk of dying from cancer, but not just from cancer, also from other chronic diseases. We've also looked at how much cancer could be prevented just by maintaining a healthy body weight, looking at the US, the UK, Brazil and China as representatives of high, middle and low income countries respectively. And you can see that in the US and UK, around 20%, around 1 in 5, of the obesity-related cancers could be prevented purely by maintaining a healthy weight, not doing anything else, just maintaining a healthy weight. And then in Brazil and China, the numbers are lower, and that's because there are less overweight and obese people around. But if that situation changes for the worse, then these numbers will go up. So I'll move on then from talking about the science to a little bit about the policy approach that we need. So because obesity and physical activity are such crucial risk factors, it's obviously important to include them in cancer control plans. Early detection, diagnosis, treatment, palliative care, they're all critical, and so is prevention. So prevention should be a cornerstone of national control plans. And then, as we've heard, because of the strong commonality between cancer and other NCDs, it's important for the cancer community to work together with the NCD community. And that common ground, common territory, those shared risk factors, of course, is why following the recommendations for cancer prevention also reduces risk of dying from these other diseases. Then we heard from Gordon earlier that it's been a sort of very landmark time recently. So just on Monday, member states from the latest World Health Assembly voted to adopt a so-called omnibus resolution. And that included global targets and a global monitoring framework for the prevention and control of NCD. So we now have a global framework within which to work on NCD prevention, with an overarching target of reducing the preventable deaths by 25% by the year 2025, and then these various targets that were mentioned earlier around the different risk factors. And I've highlighted the two targets that are relevant today for this talk. There's a target you can see on obesity, and one on physical inactivity. And of course, the key issue is how to achieve those targets on obesity and physical activity in a way that contributes to the overall reduction in premature mortality. And apologies, the formatting of this slide's gone a bit strange, but the point was to make that over the last 10 years or so, quite a few authoritative reports, strategies, action plans have come out that give us a general steer of the direction that we should be going in. And an overarching theme between these reports is that if you really want to affect change, you need to go big, go bigger than the individual, and to look at the broader environment in which populations live and eat. Because by doing that, the aim of that is to change the default setting of what we have now, which is quite an obesogenic environment, where the default setting is quite an unhealthy one. To change that to a situation where the default setting is the healthy setting, whereas, as we heard earlier, the healthy choice becomes the easier choice, not the harder choice. And then the reports also have other themes in common: the need to address the determinants of people's choices around physical activity and food, for example, the need to look at regulation where appropriate. So they have general themes that give a useful general steer. And then over the last couple of years, more evidence has come out in terms of precise types of policy packages that we need and are more likely to be effective. And that's reflected in the second component of this omnibus resolution, which was adopted on Monday, and which has been mentioned by Gordon already, the new WHO action plan, which has just been endorsed and adopted by member states. So the action plan provides better guidance than we've had in the past, and it provides a kind of menu of options, of policy options for consideration. And I've just pulled out the top line ones around healthy diet. So the plan looks at a changing environment through, for example, reducing marketing, economic tools, nutrition labelling, and public institutions and workplaces. And of course, under each of these headings, there's a huge amount of detail about the different options and strategies that can be used. And then in terms of physical activity, again, the report, these are the top line headings, for example, the importance of urban planning, the importance of physical activity in schools, community-based campaigns, and so on. So this information provides better guidance than has been the case before, and a much more comprehensive portfolio of policies. But it's not like governments haven't been doing anything. And I've just listed there some examples in those 4 areas that were highlighted on the other slide, where governments have been taking action. This is talking about diet. But some of the issues have been that although that action has been taken, it hasn't been comprehensive, it hasn't been joined up or coordinated. And there has been a tendency sometimes to prefer informational, educational approaches above a policy approach. And then there have also been challenges, there have been issues that have been raised, for example, by governments, by the private sector, by academics, about why policy action may be ineffective. And so cumulatively that's led to perhaps a bit of a halting development of policy, a bit of a fragmented development of policy. And also fuels the development of myths around policy making, around physical inactivity and obesity. And here are just a few of them. So, for example, there's no point in doing anything because government intervention won't be effective. And a big piece of that argument is that there just isn't the evidence base there to demonstrate what are the most effective policies to lead to the most effective healthy outcome. And this is an area that WCRF International is particularly focused on, which is the evidence base. Because there is an evidence base there, it just hasn't been perhaps as well interpreted as it could have been. And then the argument that you shouldn't do anything because it costs too much money. Government intervention is costly, and of course it does cost money, but not as much as it would cost down the line in treating gazillions of people for obesity-related or for developing NCDs. And then I guess the nannying argument that government intervention takes away people's free choices. It's paternalistic, it's nannying. But of course it's not like we have a blank slate. So the current food and physical activity environment already affects people's choices. It already shapes how people decide to act around food, nutrition, physical activity. It just does it in not a very healthy way. So WCRF International is focused on doing work to sort of dispel these kinds of myths because of our interest in the evidence base. And there's lots of scope to sort of look at that and work on that. And I wanted to show you something that we're in the process of developing at the moment. It's very much a work in progress. And it's the so-called nourishing framework. So this is looking at food policies to address obesity, so it's just looking at the nutrition side. And the idea is that this provides a sort of way of categorising the many different policy options are available in a way that hopefully is helpful to decision makers in terms of making decisions around policy, and in a way also that's complementary to and supportive of the recently adopted new Global Action Plan on NCDs. And the concept is that if some kind of policy is implemented in each of these areas, then that will give a comprehensive portfolio of policy approaches to tackle obesity via nutrition policy. And so, in the same way that we systematically review the evidence on science, we're also looking at the policy evidence in each of these areas, and I just listed the top 4 there. So the idea being to look at where is there evidence that's convincing in these various areas, and where the evidence is convincing, what does that mean? What does that point towards in terms of an effective policy response? As I mentioned, it's very much a work in progress, but what we hope is that through developing this, it will be a useful tool, as I said, for decision makers to help guide decisions, obviously taking into account of their own priorities and the national context, but to help go towards the achievement of those overall global goals. So finally, just a few summary key points. So there's convincing evidence, as convincing as it's possible to be in science, that overweight and obesity are associated with increased risk of cancer and physical activity with a decreased cancer risk. And because of that, obesity prevention and promotion need to be, and physical activity promotion need to be core as part of cancer prevention plans. And because of that shared common ground between cancer and other NCDs, it's important that the different communities work together. We have the steer from the various reports, and we now have a global framework to work within. Governments have been taking action. They can now take more action using the Global Action Plan. And the evidence is available to point to the policy actions that can be taken. And of course, the more policy actions that are taken and that are implemented and evaluated, the more that will help to build the evidence base to see what works. So, thank you very much for your attention. I hope that you found that useful, and please do have a look at our website, see what we do. And thank you very much. Thank you.